remember from my mission in Somalia, in the war in Somalia in '93. When I was talking with young soldiers, I was always very surprised as a military psychologist to hear about the way in which they were so eager to see how it was to shoot at someone. And then after the first shooting experiences, they told me, it's so strange when you look at a film, at a war movie, and you look someone who is being shot, it's like he is pulled away, blown away, like for 4 or 5 meters. But in reality, when you shoot at someone, he just falls on his knees and then he falls over, and it's not so spectacular. Our young soldiers were also keeping their record, and they could tell me, I've shot 11 guys, I've shot 5 guys, and so they kept some kind of a record. And within the organization, there was a split up between those who already shot someone, those who already had real combat experience, and those who didn't. Now, Somalia was also one of these operations in which a lot of Western troops were faced with not only the adversity of war, but also the misconduct of their own troops. There had been troubles within our Belgian not firefighters, our Belgian light fighters, so the paratroopers. There had been trouble with the 3rd Canadian para battalion. There had been Italian soldiers who misconducted themselves. And for me, this was the beginning of trying to understand how war always leads to some kind of norms transgression. And it's very scaring if you consider that each one of us has the capacity to turn into a beast, and how difficult it is to keep on track with normal norms and values. I will share my screen and go to a presentation which I named the Survivability in Combat, from individual rationality to collective irrationality. So if you look at the battlefield, it's normal that soldiers on the battlefield are confronted with fear of dying, but not necessarily fear of dying. For young leaders, this also becomes fear of making wrong decisions. Now, the fear is necessary in order to mobilize the resources which are necessary for survival. And in fact, these survival reactions, basically, we have 2 of them: stimulation and inhibition. It's not so difficult. It's some kind of autonomic, instinctive, and also automatic behavior. A behavior depending on the animal brain of the human being, but also influenced by the level and the type of training. I remember the problems we had with well-trained commandos and paratroopers when we sent them into peacekeeping, because they were simply not fit for peacekeeping. They were trained in an offensive way. The stimulation response, the body calls on its resources to face danger, and this also gives way to what we could call, like, as military psychologists, could call this dissociative behavior, dissociation. In a lot of cases, if you look at the behavior of heroes, a lot of the behavior of heroes is based on dissociative behavior. Then there is the inhibition, which slows down the individual in his approach to risk, but also slows down the survival reactions of soldiers. Now, each of these reactions, inhibition, both inhibition and stimulation, can take a normal but also an aggravated form when the terror quantity is exceeded. This is something we know from our clinical practice, and we know it from the window of tolerance concept, where We all have that kind of window. When we stay within the window, we stay within normal integrative behavior. When we exceed the limits of the window of tolerance, we get into hyperarousal. That might mean some kinds of panic, flight response. Also panic fight. It's well known that in a combat, most soldiers who shoot don't even aim a target, but they just shoot. They shoot, often they shoot out of reaction. It's also some kind of common knowledge you have. I've been an infantry officer myself, and I remember when we had exercises with real life ammunition, that it was very dangerous in certain moments. When someone started firing, everyone started firing. So it's a very contagious behavior. Fear is contagious, activation is contagious, but also slowing down is contagious, and sometimes this leads into a total immobility of a whole group of people. You might also leave your window of tolerance into the hypoarousal condition, and at that moment, there is a collapse of all your defense systems. Now, what's interesting, if you look at the beginning of an operation or the beginning of a war, like this has been the case in this war in Ukraine, at the beginning, there is some kind of formal organization. So there is the organigram of a military unit. Now, this organigram in combat situations is very quickly replaced by some kind of informal organization table. Now, what also is interesting is that the troop splits up into active fighters and passive fighters. What makes people go into active fighting? A number of variables: quality of command and leadership, certainly. By the infantry, we always said lead by example. Group cohesion, we could also call this the esprit de corps. So the spirit of the mind, the spirit of the fighting spirit, the mental readiness. Also the hope of victory, and what is very important in this case, the correctness of the cause. So fighting for your country is one of the highest goods of the soldier. Confidence in the proper conduct of combat can be affected also by surprise, by the wear and tear of surprise. Common experiences, I took this from Carl Castro's series of studies. What are common combat experiences? Receiving incoming artillery, rocket, mortar fire, being ambushed, being shot at, being threatened, sometimes even being engaged into hand-to-hand combat, seeing injured, wounded, or dying enemies, or being responsible for the death of a non-combatant. Let's say the collateral damage. Knowing someone being seriously injured, in this case, it's an American study, so it was seeing seriously injured Americans. I received from Ukraine, from one of the Ukrainian colleagues I know very well in the meantime, I received a question: how can we work out some kind of immediate support protocol when someone dies at the front and the comrades has to continue fighting? What can we do just to push the pause button and have some kind of a short ritual, standing together, doing something? And that's some kind of stabilization protocol I worked out in Estendam, and I hope I will have some time to share it with you. Now, there's also knowing someone, having someone you know really well become a casualty, having to help wounded people yourself, even in times where you feel helplessness or usefulness, having your body shot. So these are common experiences, and I think we've all seen the images and know that it's always difficult to know what's really going on and what's true or false, but I think that some images don't lie. Especially when I see our own journalists and war reporters go to certain zones, and when they tell us what they see, what they witness. I think we really don't need much more images to know what's going on. Seeing destroyed homes and villages, dead bodies, disarmed civilians, witnessing violence, shelling of villages and cities, people having to handle and uncover human remains. These are also the experiences our American friends had in both Afghanistan and Iraq. So we know what this can do with the human mind. Now, as I said, the actors of combat, the formal structure of in the organization table is soon, once combat starts, superimposed by a psychological structure in which you have another hierarchy than the formal hierarchy. Those with most influence, you could call this also transformational leadership. Those with most influence are those who are most active in combat. So men are unequal in their capacity to fight. Even when they have the same training, it's only a minority who will fight. It's a minority who will make the change. But this minority can win in a proportion of 1 against 20. That's something very important to tell when you train people. So I retired from the armed forces now since the month of January, but I'm into training of special units and special police units. And that's always something which I share with the trainees, saying, if you believe in victory, victory could be probable. If you get captured, the very first thing to do is to remember that you have to keep the permanent will to escape. You need a permanent will to escape and to survive. And each occasion you get, you have to try it. So don't lose your will. Don't lose the fighting spirit. Don't lose hope. Always look in front of you. There is also what we call la zone de mort, the dead zone. And I call this, I compare this like some kind of a black hole. A black hole which attracts, with in the proximity of the black hole, the laws of physics are changed. And in the proximity of that, the normal psychology also changes. That is a highly gravitational object that transforms people and people's lives. So to engage in a fight is to enter a struggle. You get into a struggle, into some kind of a bubble of violence, and into that bubble at a certain moment, you don't even feel fear anymore. The worst is to get out of it and to wake up from the nightmare. Fear on the battlefield is useful, but at a certain moment, you don't feel the fear anymore. And you fight for the one who's standing next to you. So we should teach unexperienced soldiers how to cope with the physiological and the psychological symptoms of combat stress. Into combat stress support, so immediate support in cases where colleagues, soldiers are in a state of combat shock, they should learn that the most important thing is to engage their friend who is in shock into a cognitive way of behaving, to start up the prefrontal cortex again. Because in these cases of shock, it's the sympathetic nervous system which takes over. This system is intended for exceptional business, mobilizes and directs the body's resources, takes precedence over the system parasympathetic nervous reactions. But the most important is to get someone out of a state of shock, and it's not so difficult. So again, the shock might be a stimulation shock. So one sometimes who's getting out of control and going into a panic spiral, or someone who's getting into a stupor spiral, into inhibition. That's what I told you also. This has to do with what I told you from my own experiences from Somalia, the baptism of fire, the first confrontation with fire. Soldiers, unexperienced soldiers should be prepared and have real expectations of this first encounter with horror, because in the first moments they might floral horror. There is some kind of enthusiastic apprehension with the first time when they will be engaged in real combat, and there is an enormous gap between their expectation and the real experience, the real face, the real moment on which you face the violence, the reality of combat. Like Paul Lantier said already in one of his publications, coming from the First World War and the war into the trenches, first, the danger is unknown. We sweat, we tremble. Our imagination amplifies it. We do not practice reasoning. Subsequently, we discern. The smoke is then harmless. The whistle of the projectile is used to predict its direction. And we always say when we hear the missile is for us. We no longer stretch our backs in vain. Shelter is only there usefully. Danger no longer dominates us. We dominate danger. Everything is here. Every day trains us to courage, to know the same dangers. The human beast rears less. The nerves no longer tremble. Conscious and continuous effort to achieve self-control works in the long way. So this means we, over time in combat, we become braver and braver. But trauma will be waiting for us once we get out of combat. So after a while, the inexperienced soldier in sustained operations becomes a sum of experiences and instincts, a specialist. He starts to know everything. In the beginning, he didn't know anything. After a while, his ear instinctively controls noises, smells of chlorine, gas, powder, corpses, and all the nuances that separate them. He knows how to shoot with heavy and light machine guns, how to use grenades, not to mention the hand grenades, the rifle, etc., etc. He knows mine warfare. So he becomes the sum of experiences. And then there is what we call the O center, which is the center of conscious attention, some kind of a periphery, the periphery around the information, the center from which information is retrieved and processed automatically. Like someone who reads the newspaper while walking and avoiding all the obstacles in an automatic way. That's what a soldier does. You might say some kind of a tunnel vision. I think also that this O center, on which I've read a lot of things, this O center is also the tunnel vision from someone who is a dissociative behavior. It's about peri-traumatic dissociation. The soldier is almost as frightened in the beginning by a shell falling 100 meters away as 10 meters away, and this changes. With time and experiences, the fear does not go away completely, it remains, but it becomes useful. It becomes automatic. The use of fear becomes automatic and pushes someone into adaptive behavior. I see this also in our most experienced special forces. They don't adapt to civil society anymore. If we diagnose them, we can diagnose them with PTSD, but when they go back into combat, they stay very efficient. Finally, it should be noted that the blues, so the new ones, are afraid of behaving badly in the first combat situations because there's the social status within the group. But for the more experienced soldiers, it's the fear of mutilation which is dominating their reaction. And for leaders, for officers, it's the fear of making the wrong decision in which man might die. So habituation is not synonymous with psychological reinforcements. Habituation means that there is habituation in movements, in reactions, but it does not mean that while combat goes on, that there is no more damage done anymore to the soul, to the whole psychology of the soldier. What we gain in a technical field, in the art of approaching the adversary, we lose on the other side in nervous force. So when the war lasts, when combat stays, when a war goes on, the more and more wear and tear will be felt by soldiers. Um, a British medical officer during the second or the two world wars, and he wrote about it, compared it to a cycle of seasons of wear and tear of bomber crew, saying the pilot is going through a period of summer, a period of confidence and success, but the summer months go by when fall rolls around and the pilot's picture of distress is still different from that of the soldier on the ground. So over time, there is the wear and tear. How long can one stand in continuous operations and combat? Studies shows, like the study of Swank and Marchand, shows that after 60 days of continuous combat, 98% of the survivors already have psychological problems. So if we think at this war in Ukraine, who is already lasting for 3 months, you might imagine that most of the fighters are already in a fragile state, a psychological state. The expenditure of energy required with each step to advance under fire, the effort to avoid danger at all times while seeking to accomplish one's mission, puts the individual in extreme psychological strain. As a consequence, the end of danger will cause decompression. So it's when you start resting, when you step away from danger, that the collapse of the whole system might appear. So it does not the end of fighting does not always only mean relief, but also entering a new phase, the phase of decompression. After combat, due to the continuous strain and effort, soldiers collapse physically and then emotionally. From the start of the action, the troops will split up according to these survival reactions. We already spoke about simulation and inhibition. Each of these reactions can have aggravated forms. Okay. As Ernst Junger described his first fight, my nerves gave way completely without care for anything or anyone. I set to run like crazy through everything. So this also makes me think about some kind of a dissociative behavior, going into functional behavior, stepping away from emotions. The battle is like morphine. As long as battle goes on, a number of reactions, emotional and psychological reactions and danger might not be felt. Soldiers seem to step away, to come into some form of detachment from the immediate collapse or emotional breakdown. Which behaviors are supportive in combat? Again, I went to the series of studies of Carl Castro and his colleagues, and I found it very interesting to see that soldiers with combat experience were more likely to report that their non-commissioned officers failed to exhibit clear thinking under stress. So soldiers are looking at their leaders the whole time, and their behavior is really very strongly mediated by the behavior of their leaders. Counterproductive behaviors in combat, they increased from the no combat experience condition to the low and high combat experience condition. Every counterproductive behavior. Junior enlisted soldiers reported that their NCOs often or very often tried to look good to higher up ranks, or showed favoritism, which is very, very negative for the group cohesion. And overall, few junior enlisted soldiers reported that their NCOs demonstrated courage. So that means if you have a leader who shows courage and determination, troops will follow him. That's what I also called the transformational leadership. The active actors in combat will be those who will be followed. So I think this makes my time up. I really tried to stick within the time, so I'm now open for questions, and I hope that you took out some important points out of this short talk.
Thank you, Erik. If you can close the slides,
Yeah.
then we will see.
Sorry. Yeah. Okay.
Then we will see everybody, and this Q&A will be moderated by Dr. Jetley from Canada and myself.
Hi, everybody. Erik, thanks very much for that. That's really a great setting and very timely for what's going on. I have a few comments, but I don't know if anybody else has any burning questions first. And I mean, I'll kick it off if that's okay. Erik, one of the themes that comes up a lot for me, and I remember last time I was visiting Israel and sort of at the north near Lebanon, and for a lot of us, the difference between, and Somalia is a great example of sort of these expeditionary wars that we fight in countries like ours. We often go away, and I just know the stakes of failure or what happens if you make a mistake when you're protecting your loved ones that are a couple of miles or kilometers behind you. So how do you think this changes when you're actually fighting on your home front for your own country and your family is sort of counting on you, and I think it amps things up. If you have any thoughts on that, that would be great.
Well, I think that the most important difference is, I once wrote a paper on this with Paul Bartone, who was a friend working for the United States Military Research Unit in Heidelberg in Germany. And we found out that in a lot of our troops, expeditionary forces, peacekeeping and peace enforcing troops, that they had a lot of difficulty in finding meaning for their mission.
Yeah.
Asking themselves, why do I do what I do? And we compared it to the paradigm in social psychology, the paradigm of Seligman. Seligman, who was shocking dogs. And when the dog had no escape, when the dog did not learn to have control over the aversive stimulus, he showed a learning deficit, an emotional deficit, and a physiological deficit.
Yeah.
So that's the paradigm of learned helplessness.
Yeah.
And that's what we also found in as a paradigm for explaining the behavior of our troops. When troops are living in difficult or terrible conditions, but they find meaning, that's the control over it. Then they continue to adapt, that's their mental escape. A lot of our troops had no mental escape. But let's say the Belgians who were sent for 4 months to Somalia, and then they left the country with a lot of casualties and with even 5 of our troops dying. And they didn't find a meaning. But when you're fighting for your own family, for your freedom, for your country, the meaning is into the mission itself. You don't have to look for the meaning, and that's the mental escape you need in order to justify what you're doing.
Yeah, no, I think that's a great answer. And I think there, the other point about leadership, of course, sometimes leadership's challenge is to find meaning in places where people are struggling with that, and maybe when you're fighting in your own home, the finding the meaning of the combat may be more possible. Any other questions, comments, folks?
Yeah, there is a question from our Ukrainian colleague Orest Suvalo. So thank you, Erik, for your interesting presentation. From your experience, what are the must-have points to prevent disorders after returning from combat in military and civil mental health system?
In the military, I think that we should look at the experiences with the decompression programs, not just release soldiers coming out of a war and release them into their villages or their families, but first keep them together for a certain moment. That's why we had in most NATO armies, we had these third location decompression programs in which, for example, troops from the French Foreign Legion coming back from Afghanistan first went to Cyprus, stayed there for 3 to 4 days, received some psychological and medical checkup, received some training in how to cope with your family, etc., etc. And there was first this adaptation to the civil and normal society, because when you come out of combat, don't underestimate this this permanent state in which you are on a functional aggressive level. So if you would engage soldiers coming back from combat and you would engage them in team sports and you make them play football with two teams against each other, they would kill you. They would kill each other in football. So that's why we never, in these decompression programs, we don't engage them in team sports in which there is challenge, because they continue to fight. So first there is the need to lowering this functional aggressive level, and then they should readapt to what is a normal environment with normal sleep and with without incoming mortar fire, etc. So the adaptation should not take place within their family. And I like the concept, the original concept of jihad, where the little jihad is war and the big jihad is the fight you lead with yourself after the war.
Thank you very much. And probably our next speaker might talk a bit about the prevention in a civil situation. But we have two questions. I will now read one in Ukrainian, and yeah, Rakesh, maybe you can check the English one.
Стати англійською.
Війна наразі не така, як була у Другій світовій війні. Зараз це війна машин. Солдати можуть не бачити один одного. Працює артилерія, авіація і дрони. Є дослідження, що відчувають солдати в таких війнах. Як боротись із страхом у цьому випадку?
I didn't understand everything, Irina.
Okay, so this war is totally different. This is a war of machines. You know, people can, so warriors can even not see each other because they fight with artillery and weapons. And the question is there any studies what those soldiers might feel when they combat with weapons, and how to fight with fear in this situation?
It's a good question, because more and more the human is seen as a factor in a machine operational environment where the human is the decision-making factor. Even the human fighter is more and more seen as a platform, a carrier of systems, a system of systems. So you might think then war is going to lose its human face. No, because it gets difficult when the human operator sees the results of his actions. So I think that's an important feedback we have to provide when people are thinking that it's just systems shooting from a distance and we don't see the other. I think it's important to always have this feedback about what are we doing, even because we have to stick to our norms. We cannot all move with to this war morality in which we lose norms. So that's exactly what we also do with our fighter jet pilots when they have to bombard, when they have to shell certain positions. They have to know, what am I doing and what has been the result of what I have been doing. Now, the fear might be there when you don't see the other and you don't know what kind of weapon is going to hit you, but that's some kind of useful fear.
Thank you.
Thanks, Erik. There's a couple of questions in English, and I can sort of combine them, and it's what probably you and I have talked about over beer over the years. But so when people come home, you know, what are the must-have points to prevent disorders from returning home? And the second question is, knowing that people are going to have difficulties, They may be reluctant to self-disclose information about trauma. How would we better get alliance with people that come home and have difficulties? I mean, an idea of screening, proper diagnosis, care. So how do we get soldiers that are coming back struggling to sort of open up and disclose and seek the help that's needed? And you have 30 seconds to answer that very simple question.
Yeah, okay. Well, I think one of the most important things is to try not to see them only as heroes, because when you say you're all heroes, they will not disclose anything, because that's they will shut up.
Oh, we have lost Erik, I think. Yeah.
Hopefully he'll rejoin. I mean, I can start with that. I mean, you know, Canada, US, many of our countries, I mean, I think it's multi-pronged. I think the idea of creating a culture in which psychological difficulties after trauma is a legitimate injury, right? I think if we create that paradigm, start that paradigm at the home front in training, you know, in Canada, we sort of use the word operational stress injury to put the footing. You know, if an IED blows up and people have concussions and people have missing limbs or they have PTSD, they have legitimate injuries. I think that's an important thing to expect. I think these can happen at the home front. They can happen in training, all of this stuff. So it really begins with a language. Leadership needs to understand this. And just like we have concussion awareness in sports, it's now courageous to take a knee if you've been injured in rugby or in football or this kind of thing. We create that same kind of cultural change. So it's not really the job of the health system, in my opinion, to go running around knocking on people. The whole culture of military needs to change. And I don't think people, if they hurt their shoulder, if they hurt their knee, they will go for care. It's the same kind of idea. So to put the psychological injuries on the same footing, I think screening, education, reducing stigma, all of those things are effective as well. But really, it's the cultural change, in my opinion, that needs to happen. And that's, you know, what, and we all come from the culture, the country that we're in. So I think that in many ways, our countries have to change. And you know, the chief warrant officer of one of our army bases close by said, you know, 20 years ago, I thought the courageous person was the one that sucked it up. But now I see the courageous person is the one that puts their hand up and asks for help. So that cultural change, I think, is really important. That has to happen, you know, within uniformed personnel. And I think, thankfully, I'm seeing it. I'm seeing it more and more in the younger generation. The stigma is going away and things, and people are not afraid to admit that they're stressed or they were doing things like that. And I think when Erik talks about the transformational leader, a good leader does a debrief after an operation and says, I was scared too, right? Like, and acknowledges that. So I think there's a piece of that. Hey, Erik, you're back. So we missed you. We just talked briefly about sort of the necessity of cultural change, really, to have people come forward. So I think that's it. And I wanted to ask sort of one other thing, and I think it's really, again, the challenge that lots of us have. I mean, in 1980, you know, we coined the term post-traumatic stress, and that word post kind of implies, and for lots of people, it's after you've been raped or after you've had a car accident. But of course, with police, first responders, and military, there often isn't a post, right? There often isn't a post. The trauma is ongoing, and we have to somehow help to win the war. Think about all the literature that came out of World War I, the Pies Principle and all of this wasn't really about helping people not to feel sick. It was to keep the fighting effectiveness. So I think we're almost talking about, instead of post-traumatic, we're almost talking about intertraumatic or ongoing traumatic stress and how we manage that while the war is going on. So I don't know if you have some thoughts on that, which is, again, I'm sure with the firefighters and people like that, you certainly have seen a lot of that over the years.
Yeah, you're right. The difference with the soldiers, police personnel, warriors in times of war is that they have to they need support, but also they need the closure of things and go to the next one. So you never take the time during your career, during active career, or during the operation. You should not take the time to go too deep into your emotions. you need to be helped, to get structured, to get counseling, to get tips. But once someone starts to ask questions, how do you feel about what you're doing? You're not able to do anymore what you have to do. And then there's the other aspect. So like before my battery went flat, just to end this sentence, as I was saying, don't make heroes of everyone, because when you look at them only from the position of the hero, they will not disclose, because you already rewarded them with medals. And in fact, you're saying, shut up, you're a hero, so it's okay, and keep the rest for yourself. So we should certainly also consider, and maybe that one might be one of the next hot topic talks, we should consider the handling of moral injuries.
Yeah.
Thank you. And I think we need to move forward, yeah, to our clinical case presentation. And afterwards, we can go back to this discussion and hear more ideas and hear more.
Thanks very much, Erik.
Expert opinion. And I'm glad to introduce, here we have Professor Ursano with us as well. This is really nice to have another expert with us. So please, Oleh Hukovskyy, a psychiatrist and psychotherapist, body-oriented psychotherapist and volunteer, who will now present a clinical case and will state his requests afterwards. Thank you, Oleh.
Thank you very much for inviting me, and very short reflection to the last topic that was mentioned about heroes. Like I found out, like for myself, that when I see somebody dies on the war, like from soldiers, I stop writing glory to hero or something like this, but I am mentioning as a warrior. And I think this changing of definition from hero to warrior, it make it more grounded, and then family can get better support, because if you're already hero, like you are getting already the highest reward. So I'm totally agree with my previous speakers. And my case, what I want to represent, I think it partially connected about survivability. One little correction, I will talk not about military hospital, and this is the point. I will talk about civil hospital and our regional civil hospital. And this is the case because like several weeks ago, it was a request from one doctor in which department a lot of wounded soldiers came, and it happens in many departments in this hospital. So it was massive massive coming on wounded soldiers to the hospitals where did not have any kind of so massive experience with wounded soldiers. So, and this was a request from one wounded soldier who asked, I would like to have psychology support. So this, our project, let's say, social project started from request from one soldier. So it was not top down, it was as a grassroots kind of movement. I will share my screens and I will try to follow several steps what we did during last several weeks, and I would like to stress some important points, and I really would like to get any feedback how it goes in international context in such kind of work. Okay, so the project is psychological support of wounded soldiers and cooperation between hospital and professional NGO. So I call it like this. And since 2014, I have like many years of experience working with soldiers and veterans, but mostly it was a work for homecoming. So I work mostly with veterans who finish some stage in their military life and come back to civilian life. And so yellow color, it was my main area of work. And with the full invasion, like I focused on the other parts of the warrior path. So it's pre-deployment, deployment, and I'm collecting different international experience and Ukrainian experience about effective programs of self-care and body care. And one moment it's about psychological support during hospital care. So in this presentation, I will try to follow some steps. It's about mission of our team, because I'm not the only one who is making this support. I am more in the role of project manager, but there is a very cool team of skilled professionals who are doing mostly operative work. So our mission, I think our mission is to support wounded soldiers while they are in the hospital and connect them to resources. And in this idea of decompression, it seems like we have now 70, if I'm correct, 78 days a day of the full invasion. So it's like beyond the limits of 60 days that Erik mentioned about participation in the like acute combat. And now these soldiers, if we can think in the terms of decompression, now these soldiers got decompression experience because of they are injured. And they, because they moved to another side of the country and in a full peaceful region. And like our region was almost not attacked. Since that, like a lot of air sirens, but not really damage. And this is, in my opinion, also can create some issues about this huge contrast between combat field and civilian field. And the aim of our team was not so from the first time when we come to the hospital, we create a memorandum and agreement with the doctors and the head doctor, like we have our area of responsibility. It's about psychological support. It's about psychoeducation. It's about covering emotional needs and support into recovery. Because as I remember, Norman Sartorius said that there is no health without mental health. And this is our area of responsibility. But we are not putting diagnosis. We are not prescribing treatment. We are not making evaluation. So we are not affecting this sometimes very bureaucratic part of the job. So we are doing what is impossible to do in state institution when you have 1 or 2 psychologists for a whole hospital. And we collect, like we gather 15 professionals and even will be more. And we cover 7 departments. And there is strengths, like strong points of our team, like so professionals with many years of experience, because war already goes for 8 years. And there are many professionals who gather a lot of experience. And we are part of professional association, so we have ethical code, and we are aware about the main principle in medicine and in psychology, not to harm. Noli nocere. We are open system and with clear boundaries. So memorandum is about that. And we, since the beginning, we create our system of support. So it's our team meetings, and tomorrow we will have next one. We invite several mentors, and we invite one supervisor who has a very big experience working with veterans and militaries in Kyiv and other cities. Another strong point, and I think this point is very underestimated. From my experience in Ukraine, it's a peer-to-peer support. So I have many years working together with veterans, helping veterans in their transition. And I believe that this pair, when you provide professional frame and you can give some methodological knowledge with experience of battle experience of veterans who create this strong connection as a role model, as the representative of the same culture. I think this combination it's probably most effective what I met, and I think this point is very underestimated. And of course, our focus on building up resources and mentorship, I already mentioned. So, and for example, about peer support, on the first meeting into a clinical ward, I invite one friend, he is veteran with high amputation. And when he came to the one department where guys were with some small shots, I would say small shots compared to his experience, I think it was already something. So he injured much more than these guys, and I think even this comparison can create better self-esteem, and they created very good bonding, very good connection. And yesterday I met with one veteran who was a gold medalist also on Invictus Games, Igor, and he also agreed about providing some support for wounded soldiers, for example, through any educational videos, because he also finished our biodynamic foundational training. So he got some psychotherapeutic education, and I think it supports his knowledge of what is going on, what stages veterans will go through. And he is much more able, and yesterday he was very appreciated for these tools, body-oriented psychotherapy tools, because he can reflect better, he can survive better, and he can support himself better. I think good quality educational materials is important, and for example, by Wendy Waits from United States, I got very cool breathing technique, and good flyers is helpful. Despite professional counseling, I think it's very important to create more human interrelations and connections through good rituals. And one ritual that is popular in like my community, my friend veterans community, it's a tea ceremony. So you can see the picture of doctor who and we create tea ceremony for neurosurgeons for 1 hour. So they got the smell, taste, and also the chemical importance of good quality tea, because it contains L-theanine. It contains very important amino acid. And we agreed that they will support our tea ceremonies with veterans, for example, militaries, for example, when they having dinner. And also very important to build intelligence and support intelligence. And when Erik was talking about talking squirrel, fire squirrel in previous lectures, one of the way to build the intelligence, there is reading books, and I connect with the project called Army Reads. So and they sent, I'm waiting, they sent several books about history, about military arts, and so on, so on. So people, when they are stuck in the hospital, they don't need to stuck to the phones. They can read and they can develop themselves. So no waste of time. Mentorship, a very important point, to find skilled mentor since the beginning. And mentor was talking about survival guilt, very cool tips, phantom pain, for example, when you can grieve with a soldier about the leg or arm, and he need to go to the surgery and make an amputation. So you will not have phantom pain if you can really let go, if you can really grieve about your limb. International mentor about team building, about how to manage the process. And I think in this game, let's say, it's very important to find benefits for all players. So, and there are benefits for soldiers from this cooperation, for hospital, for psychologists, and it's important to be aware. And like some short recommendation for hospitals from our experience, probably there are much more, that invite teams, not separate professionals, invite functional teams. They can provide self-support also. So, and in this case, like when you have a war and like this social awareness rise, you can invite these teams free of cost. You don't need to spend money on teaching. You already got very skilled professionals who can make a work. Involve veterans and wounded veterans, provide safe place. It would be nice if every department can create safe place, like separate room where counseling can be happen, and be open for new knowledge, because now it's very important to be open systems, to interdepend, and good to sign memorandum, of course, because it's create more clear boundaries. And I had some, thank you very much for listening to that. I have some questions to Erik, and I think only first question would be like interesting, because other questions were mentioned. So about just national military traditions. I'm really curious. Thank you very much.
That's great. Any other thoughts? I mean, so I'll kick off with a little thing. I know that, you know, Barbara Sano is on as well. I think the one thing, to go back to the hospital-based and to go back to this idea is, and I think part of transition is, you know, many of our countries try not to medicalize sort of what might be a normal thing, right? So soldiers coming back from war, I mean, since the time of the Romans. So we try as much as possible, at least in Canada, and I know I've talked to my other colleagues, of really leaving a lot of this stuff in the realm of leaders, in the realm of peers, in the realm of this, because, you know, as we know statistically, you know, the vast majority of soldiers, even exposed to combat, even wounded, aren't going to develop PTSD. So part of my initial reaction would be, let's not medicalize something. Let's help people to transition. Let's normalize it, and clearly identify those that need care. And that's the second piece, is resources are always going to be limited. So if we try to do one-on-one therapy for everybody that's having, you know, some difficulties early on, we're not going to have this. And my question to you, I guess, would be, does this have to be strictly in the realm of psychology, or are there other professions? Are there other chaplains? Are there other people that can help people with this transition? So I'll just throw those few things out there, my immediate reaction. But thank you for your presentation.
Thank you, Rakesh. Is the Professor Ursano with us?
Yes, Irina, I joined late, so I only caught a bit of what I heard. I certainly agree with what Rakesh was saying, and Oleh as well, and good to see you. And I only joined with Oleh's presentation. But I would make two comments. One about, we have to remember that PTSD comes in many forms, as Rakesh was alluding to, in particular, including one that for which one recovers rapidly, acute forms of PTSD. So the idea of not burdening patients with something that they may think of as cancer, when in fact the probability of metabolizing, digesting the systems, the responses they had, in some ways, recovery from PTSD, if you think of it as a digestive process, and most people digest, metabolize the symptoms over time. Some don't and develop chronic problems. I also particularly like the focus on peer support and involvement in the hospital that Oleh has presented. Then the second piece I would comment on, only because I caught the word hero that Oleh was talking to, and I have no idea what was spoken about before him. But I would remind everyone that being called a hero is also a tremendous burden. We often see, let's say we not uncommonly see the burden felt by heroes at times, including suicide, because being a hero, one carries tremendous expectations from the community in which one is in. And those expectations to always be right, to always be just, to not have any problems in one's life. And those are tremendously burdensome.
And
so
Bob,
I share Oleh's
to
concern about saying
Yeah.
it, using it too liberally, in contrast to great job.
Yeah, no, you'd be happy to hear that Erik sort of brought that point across about hero about at least
Super.
4 times during his talk. And I think we all completely agree with, let's not burden these young people with that sort of legacy, because that's gonna, bite them eventually. So we have to be careful of how you honor people and how you respect people and commemorate things without putting that burden of the word hero on people. I think that's exactly what we need to do.
Good to hear.
I see here a professional psychologist and teacher from Vinnytsia, Tatiana Alexandrovna Komar. And Tatiana, if you want to share your experience, I know that you work with veterans as well for a long time, maybe within a hospital. Maybe you can tell several words about your experience.
Дякую.
Thank you. Yes. The parents usually come to me. The soldiers' parents came to me. Their sons were in the hospital. My experience has been more in supporting. Even after these young men were discharged from hospitals and returned home, I'm still keeping in touch with them. It's even a bit of a pedagogical experience. We're planning their training, whether they want to enter some kind of training, etc., etc. I second the speaker's ideas, who said that the initial phase of the meeting with these young men were about support. They were wounded. It was the rehabilitation institutes. There were amputees. These were young men. And my addition, those people cope with traumas better if they have a family. Family support really helps if they have wives, for instance. And naturally, in case those are young men who have no families, it's harder to work with them. They are clueless about their future. Another thing I noticed during the first phase of meeting these men is that they are willing to come back, because these are the boys who were shelled during the first days, and they said they didn't even have time to do proper fighting. They didn't have the opportunity to do that. They were amputees, and we told them it's a long journey on rehabilitation. They were still willing to use the prosthetics and to return to battlefield afterwards. Thank you. It was an extremely interesting lecture. The first lecture, the hero term really can be a burden. Thank you.
Thank you. Дякую. And Олег Сазонтович, чи ви з нами на зв'язку? Я знаю. I'm sorry. Professor Chaban, are you with us? Can you please comment briefly?
Я з вами на зв'язку. Вітаю, колеги.
Yes, welcome, colleagues. There's an air raid siren in Kiev, but I am here. The talk was very interesting. I listened from the very beginning. And what the other Oleg was speaking about, I do not like. I oppose vehemently supporting in a clinical setting. I think it's the patient's genetic capacity. There's a program for them to progenate. But what Oleh mentioned was a good idea. It's like a framing effect. It depends on who the speaker is. It depends on how the speaker delivers it. Sometimes these people are trusted. Therefore, engaging the veterans or those people who have big experience is the key in this case. Working with these patients here in Kiev, I noticed that, for example, there is no time to see those patients, and they don't have the time. They often disappear, and the psychiatrist or psychologist doesn't see them anymore. They disappear for a number of reasons. Some resist, some flee from the hospital to return to war, you name it. There are comorbidities in that case, and people are transferred from one department to another. So people who have psychotraumatic disorders also might suffer from other type of disorders, and they're transferred to a different department. Therefore, I, as a psychotherapist in general, I need to implant a roadmap in the head of this patient, a psychotherapeutic roadmap. Even if you don't have that at the moment, what do you do if it starts? It's in stark difference with psychoeducation. Psychoeducation is about many correct formal things. People read them and they forget them the next moment. But you need to have a detailed conversations with them. Talk to them about alcohol abuse or domestic violence. Telling them that they need to see a professional that would refer them to the correct professional is more important in my view. So we shouldn't fall in the fashion saying, oh, it's the war, then it's definitely PTSD and then it's stress disorder. If there's 60 days, you need to take the culture into account. There are many things that have not been studied yet. And I'm sure Ukraine will contribute to the general understanding of PTSD, because there are so many nuances we've never even thought. For example, being at war with people with whom you partially share the language, basically. So this would be my idea. The psychotherapeutic roadmap for the future. First, you establish trust and you give them this map to the patient. This is it. Nothing else needed. Unless you've done the screening already, unless you've detected the disorder, unless you're processing flashback, traumatic memories, etc., etc. This was my follow-up comment.
Thank you very much.
Without a shadow of a doubt, I agree that it's our experience that working with the families is more effective.
The reminder, of course, not everybody has PTSD. And I think the other reminder is, PTSD isn't the only result of trauma and loss, right? So we have to keep our minds open. I think for our colleague in the hospitals, I think that helping people, readjust after trauma doesn't have to always be in the realm of mental health professionals, even though I'll talk myself out of a job. So maybe smattering sort of trauma-informed care amongst other professionals would be helpful as well. I want to thank everybody. I mean, my good friend and our good friend Erik Vermetten would normally be doing this role. He's on a flight right now, so he asked me to pinch in, and it's been an absolute pleasure. And I just, really want to thank Irina for keeping this fire going. We're all saddened, very saddened by the war, and when I see what's happening in Odessa, where I was in 2018, it really saddens me. But it is good, to find some comfort amongst each other as friends and try to support each other. So we'll see everybody. And Irina, who's on in 2 weeks? It's Stephen, I think, Hopfall.
Yeah. In 2 weeks, we'll have Professor Stephen Hopfall with a presentation on 5 essential elements.